Okay, everyone, so it seems that all of you are probably more familiar with Project Echo than I am and the format. So this will be for me, and you all can just follow along, and then we'll dive into a little bit of meat. We're going to focus in these first several cardiology clinics on heart failure as a topic. So you should see a theme as we're going through the months. We're going to take different approaches to the topic of heart failure, and so that'll be kind of an exciting next couple of months. So as a reminder, we do sometimes take video and photos here, so if you don't want your mug included, then let us know. We'll just briefly go over the Project Echo model, how the clinic will be run, in particular how we'll do this cardiology clinic, and then as well as the facilitation and case presentation models. So as most of you know, ECHO stands for Extensions for Community Healthcare Outcomes, and this is really not just us participating, but it's a global telehealth platform. We started ours in 2010. I say we, but it was these folks here, and I'm joining in now. We're very proud to have been one of the early adopters of this model, the fourth iteration in this country. And as you might be aware, we have several recurring clinics that happen, which are listed on the right-hand side of your screen. So we're happy to be rejuvenating the cardiology clinic to add to this list of recurring clinics, but a lot of great topics that might be of interest to you or those you work with as well. So the hub team for this model includes the facilitators, so myself, for example, and the Project Echo staff. And then occasionally we will bring in some multidisciplinary subject matter experts to help round out our view and approach to these topics. So for example, we might include some nutritional conversations when we're talking about nutritional approaches to these cardiology topics. And then the spokes is you all. You are these multidisciplinary care teams who are boots on the ground providing care. And we're very excited to have all of you joining in from so many different places. And as you know, this is not one provider examining or seeing a patient remotely like telehealth traditionally is, but rather the idea here is to have knowledge transfer amongst all of us and to really increase our capacity for providing specialty care and access to that care by collaborating together and learning from one another. And we will be using case-based learning and plug. We really encourage you to give us your cases in advance so we can have some robust discussion, especially for these heart failure topics. So as you are probably familiar with, each clinic will have three different sections: the introductions, which we just did, and then a case presentation by one or two spoke sites. We really prefer to have these in advance. That will help tailor the conversation that we're going to have in the content on my end. And that's really where we'll have this robust discussion of particular challenging cases for you all and share our knowledge. And then we'll always round it out with a didactic presentation that gives some of the data, the numbers, current practices, guidelines, and then a lot of question and answer time as well. So we hope this will be very interactive. As you know, we will do these introductions every time so we all know one another and kind of the background we're coming from to help us understand how we all work together. And then in terms of the case presentations, we have made a brand new form for this clinic. And so we'll see how that works. It's what we think will be the pertinent information, but we are looking forward to your feedback on that as well. And as mentioned, we would prefer to get cases beforehand, and then we can pick from amongst the cases that are, I know all of you are going to submit cases. So that way, we'll just pick what are the ones most relevant to that week. But I think that will really help us with a robust discussion. So please be racking your brains for those challenging heart failure cases that you'd like to talk about all together. And then we'll, after the case presentations, have the chance for all of you to ask clarifying questions, to weigh in, and then also giving recommendations, again, starting with the spokes and then coming back to the hub here. And then we'll do a wrap up for each case. So I'm really looking forward to this discussion and particularly hearing about the challenges that you guys are facing in your clinics. So I'd like to actually start today by using one of my clinic patients and filling out the case form in real time here with you. And we'll actually generate a bit of discussion about this patient of mine, who's one of my first patients when I first moved here to Nevada. I didn't tell you by way of background for me, I came here from Louisville, Kentucky, so a bit different elevation, a bit different population. Originally from California, trained on the East Coast, so I'm working my way back towards home, but I'm really enjoying some of the new things I'm learning. For example, one of my patients couldn't make it to clinic because he couldn't get his mule to the senior center. And that had never happened to me before. So I'm having a lot of fun. Okay.
I'll just make one quick announcement.
Sure thing.
So some exciting innovation here for us here at Project ECHO. Those of you who've submitted cases before know that we had hard copy forms that you had to print out, hand fill, and then fax back to us. So starting with the cardiology clinic now, we're going to have online case forms. So the link to this case form is just on the clinic webpage. But yeah, hopefully making things easier for you. Everything's HIPAA compliant, so you don't need to worry about that. And hopefully making it easier for you all to submit cases for us.
All right, great. So we'll just fill this out together. So hopefully you'll see it's user-friendly, and if we find it's not, we can change some things. So today I'm going to be entering my patient here in Reno, Nevada. And if you want to get in touch with me, now you know my email address is there. This box is probably the most important one. I really want to know, what is your main question about the patient? What is your dilemma, your challenge, or the main thing that you want to know? And that will help us frame our discussion. So for this patient, my question is, does this patient have HFpEF? And if you're not familiar with that terminology, you will be after today. We're going to spend a lot of time talking about it. And my secondary question is her dyspnea due to HFpEF? So sort of two questions wrapped into one. So this is going to be a very helpful, as you know, when you're talking to a consultant, if you provide the question, that helps us to shape our discussion. So that's my main question that I'm interested in all of you weighing in on. We're going to discuss this today, and this patient has never been previously discussed. So my lovely patient is an 86-year-old woman. She is not Hispanic or Latino. She is Caucasian, female, and her height in inches is 65. Her weight in pounds is 182. Blood pressure when I saw her in the clinic was 145/73. This is not all from the top of my head. I have a cheat sheet here. So importantly, especially when we're talking about heart failure, weight changes can be very useful to track. Now, the patient might not always know, and that's fine. And this was my first time seeing this woman in clinic, so she's not really sure if she's had any significant weight changes. Now, the brief description is that she is presenting with severe dyspnea on exertion. So when she walks from her bedroom to the bathroom, she feels short of breath. And this is new for about 2 months time or so. And this is why she's coming to see me in clinic. In terms of prior cardiac history, really she only has a diagnosis of hypertension. And then she has this sort of strange thing where she has an unexplained splenic infarct. And she was started on Coumadin, but no evidence of atrial fibrillation, which I think was kind of the initial concern, is this embolic event. But no real reason, but she comes to me on Coumadin. No allergies. Brief social history. She's married and she's the caretaker for her husband, who's on hospice for stage 4 cancer. Family cardiac history, probably not relevant in an 86-year-old, so she doesn't really know. In terms of her pertinent medical history, she does have chronic anemia. She has suspected CLL, but doesn't want any testing. So kind of are assuming that she has CLL. She also has diabetes, non-insulin dependent. And she's had PFTs in the past showing no COPD. Important when we're talking about dyspnea as well. And then she also at one point had a chest CT, which showed some mild interstitial lung disease. At the point when I first saw her, she had not been hospitalized in the past 12 months. Now, Project ECHO, cardiology, so echocardiograms are going to be my favorite thing. Here, what I would request is if you can actually give me all of the ECHO report, that's great. There's actually an option to upload images or the report. Sometimes the summary statement is not everything I need because the reading person may not have known the clinical question. So if you can provide me the whole report, that's fantastic. If you can provide images, even better. Since I already read her whole report, I'm just going to tell you all today the important things, which is that she has normal systolic function. Her ejection fraction is 60 to 65%. She has mild mitral regurgitation, mild aortic insufficiency, and spoiler alert, she's reported as grade 2 diastolic dysfunction on her echocardiogram. In terms of other diagnostics that are important, her hemoglobin was 7 when she first came to see me. She also ended up having a cardiac catheterization, which showed non-obstructive coronary disease. I'm using a lot of the acronyms that I use in my own notations, but feel free to write this as you all feel comfortable, and we'll work together with that. And then I've pretty much already put in the procedures up here. This will become relevant if we're talking about ischemic heart disease, for example, and they've had multiple caths and multiple stents. It's helpful to know the timeline behind all of that. And then also, if their ejection fraction is changing, it's helpful to know the time frame over which those things are changing. Okay, and then in terms of labs for her, she does have a relatively normal renal function. Potassium was also normal. And here's your option to upload files if that's easier than typing things in, to upload those files, in particular, again, echo or other cardiology case results. And then in terms of current treatments, besides medications, whoopsie, I didn't even read it all myself. No current treatments aside from medications, but this would be things like CPAP for sleep apnea would be really important. If they're enrolled in cardiac rehab, other non-pharmacologic interventions, TED stockings, for example, I use those quite a bit. And then for the medications, this is the way we think will be easiest to input it. When you say yes, what we just like in this box is for you to list them, to list the relevant ones. So for example, she was on amlodipine 10 milligrams at this time. She was on Lasix at this time, potassium. And those are the most relevant medications for this. And then there's a chance for any other comments or questions you want to make if it doesn't fit into any of our boxes. Okay, so then we press submit. I actually don't know what happens when we do this. Is it going to go away, Troy?
Yeah. One quick thing.
Okay.
If you scroll back up to hospitalizations, and then you click yes, or down a little bit. Cool. So they'll just ask you for a little bit more information if you do click yes. That was just so you guys know.
Thank
Sometimes boxes pop up depending on what answer you click.
Okay, great. So I'm not going to press submit because I wanted to leave this information up. And so the way we would use this case is that whoever submitted it would then present the case in sort of abbreviated format. So I would say that I have this clinic patient. She's an 86-year-old woman. She has a history of chronic anemia, suspected CLL, but doesn't want any further interventions, hypertension and diabetes, and then an unexplained splenic infarct on Coumadin. She comes to see me for the first time in clinic and is complaining that she feels short of breath when she walks from her bedroom to her bathroom. And this has been worse over the past 2 months. And the clinical question that we're trying to answer is, what is the cause of her dyspnea? But in particular, could her dyspnea be from heart failure with preserved ejection fraction? And then pertinent data that we've entered here in particular is her echocardiogram, which shows that she does have normal LV systolic function, some mild valvular disease, and grade 2 diastolic dysfunction. She has had other workup, including PFTs, which are not that abnormal, a low hemoglobin, non-obstructive coronary disease. So now I would say, are there any clarifying questions that you all would like to ask about this patient to help you wrap your mind around her? Or any other testing that you would want or wonder if she's had?
So any clarifying questions anyone has, please unmute yourselves with the little microphone icon. Or I see some of you joined by telephone at *6. Dr. Van Gilder, yeah.
Hi, sorry, I got a little distracted, but I was wondering if she'd had any thyroid testing done.
Yeah, great question. I don't actually recall off the top of my head, but she does have a very good PMD, so I'm going to assume yes. But that's a great question.
Thanks.
Patty asked about a chest x-ray.
Yeah, good. So she didn't have a chest x-ray, but she did get a CT because she had presented with dyspnea to the ER at one point. And she had no pulmonary embolism, but she did have mild interstitial lung disease, which was a bit of a surprise. Great. Other tests or questions you might ask. You know, dyspnea is quite a big diagnosis to tackle. And I think you're all familiar with this. We sort of start down one path and keep doing different testing. Of course, I always think it's the heart until I don't. Then I say it's the lungs. But I like the way you all think of this from a holistic standpoint.
Question from Dr. Bayan, RVSP, sleep apnea screening.
Yeah, great question. She has had sleep apnea screening and does not have it, but that is my favorite of all tests to send because most people do. And then the RVSP could not be calculated on her echocardiogram. You'll see this from time to time. If our Doppler signal does not quite line up or there's not a lot of tricuspid regurgitation, we can't measure it. But great question. What are you thinking about with those questions? Oh, he's on chat only?
Yeah.
Yeah, Dr. Bayan, you can unmute yourself if you'd like.
Well, thinking about sleep apnea, right side heart failure, pulmonary hypertension.
Yeah, fantastic. I love all those questions and a very good thing to think about with dyspnea. Okay, someone asked about a BNP level. Yeah, so she did have a BNP level, which was mildly elevated when she came to the ER for that time, but nothing raging or screaming, but mildly elevated. And I will say, we'll talk about BNP in some of our other lectures. It's helpful unless it's not, right? As you're probably all familiar with that. Okay, good. Other thoughts about the dyspnea? Fantastic. So I think that, at this point she had a relatively good workup, and I'll give you the spoiler alert of what happened with her. She ended up being hospitalized because her dyspnea was just so profound. In fact, in the clinic, she was becoming so short of breath just walking back to the clinic room that she ended up getting sent over to the hospital. So we did a very large workup, including the left and right heart catheterization. So that's getting to the pulmonary hypertension and right-sided heart failure question that Dr. Bayan was answering. And, we didn't get much more information than what I gave you here. We did empirically diurese her, and with diuresis, she felt 1,000,000 times better. On top of that, we transfused her. And when we did the combination of those two things, she felt like $1,000,000. And so we ended up saying that probably this dyspnea is multifactorial for her, a combination of chronic anemia, elevation, which I'm learning really does play quite a role, especially in our older patients. And then the grade 2 diastolic dysfunction was enough for her to have this profound dyspnea. So a complex case, which a lot of times these dyspnea patients are, and we don't always get one slam dunk, but I think in her case, it was really the empiric treatment of volume overload. Now, we overdid it. We diuresed her too much. She was a little hypotensive when she left the hospital, had to hold some things, but she's to this day is feeling pretty well because we try to keep her as euvolemic as we can. All right, so that's our introduction to HFpEF as an entity, and I want to do a little more talking about that in the remaining time. I guess you can help me switch back over. Thank you. Our seamless transitions here. Any questions about that patient form while we're switching over, or does that seem pretty self-explanatory for folks?
I guess who's looking forward to submitting a case for Dr. Toft? Does anybody have somebody in mind?
Oh, good.
Good. Yep. So we definitely want. Hopefully, we get multiple of these every time we have the clinic. That's really the best way that we're all going to be learning. And so we'll definitely, if you all feel comfortable signing up today for the clinic next month, we strongly encourage it. So feel free to chat in the box. Let us know that you're looking to submit a case so we can follow up with you with any questions you have, or feel free just to speak up.
Yeah, I got you, Danny and Patty. I think will be our first two. I'll follow up with you both.
Okay, great. So let's dive in to a reminder. Please don't disclose any PHI, but we haven't really given you that opportunity on the form. So don't go rogue and put that in the other information.
Well, that's more for when you're presenting it verbally to us as well. Yeah, just none of that information, please.
Thanks, Troy. So today I just want to do some foundational discussion about heart failure. These are very familiar terms that we hear all the time, we use all the time. They're used in the lay public, they're used in medical literature, and there's actually a lot of overlap, and people aren't always using terms to mean the same thing. So I want to give you my framework for how I just approach heart failure in general and how I categorize the different types of heart failure. And this will serve as a foundation for our future clinics where we dive a bit more into specific disease entities and in particular specific treatments. So I know that's what we're all excited about, but bear with me because first I want to have some common shared terminology here. So for me, I put heart failure into two categories: preserved versus reduced systolic function. As a clinician, I think that makes sense. If you talk to a pathologist, they'll categorize this very differently. When I've worked on curricula in the past, they want to characterize it by what it looks like under the microscope. But for us as clinicians, I think that this is our most evident and obvious distinction, because this is also how our current guidelines deal with the treatment options. So just to give a little bit of numbers, you know this, but all of our patients have heart failure. This is from the 2020 update to heart disease and stroke statistics, and it's giving us the prevalence by percentage of the population by age of heart failure as a clinical diagnosis. And what really strikes me is that once you get to age 60, you really are having a large proportion of your patients that have some diagnosis. But then look at when you get over age 80, at least 12% of the population. As you probably have heard and probably have seen in your practice, these numbers are growing. We've done a great job of getting people through their acute ischemic events, but then they end up with heart failure afterwards. And so people are living with more heart failure, and it's projected that these numbers will continue to skyrocket. And there are literally millions of people living with heart failure in the United States. So people have this disease. That's why it's so important. I think the most important point that I want to drive home today, particularly when we get to talking about preserved ejection fraction, is that heart failure is a clinical syndrome. It's not actually a diagnosis of something wrong with the heart. It is the clinical syndrome and constellation of symptoms. And so this is something that I learned as I became more in the cardiology world, is that there's a difference in between, and you'll hear cardiologists say this, cardiomyopathy, which is how we refer to the disease entity itself, the problem with the heart, and being in heart failure. Are you all familiar with people using that terminology? They're in heart failure. And we'll ask each other that, well, are they in failure? Now, what we mean is, it is possible to have a patient with an ejection fraction of 10% who has no clinical symptoms of heart failure. Have you all encountered these patients in your practice? They're essentially asymptomatic. I had a patient who would go to the gym 5 times a week and lift weights with an EF of 10%. So he was not in failure, but he had cardiomyopathy. This is an important distinction because through the course of their life, things are going to wax and wane. They will have what we call heart failure exacerbations, for example, or acute decompensated heart failure. That is being in the clinical syndrome of heart failure, but they can have a disease, a problem with their heart, and not be in heart failure. I think this is a useful way to think about this in our mind. So when we think about what the clinical syndrome is, we're all familiar with these symptoms, but to remind us, dyspnea, particularly on exertion, is one of our primary symptoms, and also super hard to pin down. That's why we started with that patient. And if you're familiar with the New York Heart Association classes, this is a way to divide people in terms of their symptoms. So we go from New York Heart Association class 1 all the way to class 4. Class 1 means no symptoms. Class 2 means symptoms with moderate exertion. So they go up a flight of stairs and they feel winded. Class 3 is symptoms with mild exertion. So walking around their house or on a flat surface with a half a block, they get dyspnea. And then stage 4 is when they have symptoms at rest. And this helps us in a shorthand way to just know how bad is it, how bad are their symptoms. And then I think everyone's familiar with lower extremity edema, but don't forget to think about other places that people, quote, hide their fluid. And if you have someone who's had longstanding cardiomyopathy, they'll often know where they put their fluid. So some people, it's all in the belly. They will have dry as a bone chicken legs, but their pant size increases 2 sizes over the course of the last month. Other people, especially if they're laying in bed, if you're seeing them inpatient, it will all be in the sacrum or dependent regions if you have someone who's more bed or wheelchair bound. So it might not be on their calves, but then you go up to the hips and you'll see some pitting edema. And then of course, pulmonary edema is usually the one that gets people's attention and why they come to see a healthcare provider. Isn't it amazing how people will live with leg edema, but then it's when they can't breathe that they'll show up to see us in clinic. And then our other symptoms of orthopnea, or having to sleep on multiple pillows at night, and paroxysmal nocturnal dyspnea, where we're waking up gasping for air. Now, I think some of you astutely asked about sleep apnea. I find it very difficult to distinguish sometimes between the gasping for air of sleep apnea and the gasping for air of heart failure, which is why everybody gets tested for sleep apnea more or less. So I think we're familiar with these clinical syndrome, but this is very important, particularly when we talk about HFpEF, so we'll get there in a moment. So this is my view of the world. This is how I think about cardiomyopathy. It's systolic or it's non-systolic. You may have heard the term HFrEF, heart failure with reduced ejection fraction. This means there's a problem with the squeeze of the heart. So there is systolic and non-systolic. Let's talk first about systolic failure. Again, here I just have two main categories, ischemic or non-ischemic. That's because far and away, if you're a betting person, we're in Nevada, right? If you're a betting person and someone has cardiomyopathy, it's going to be ischemic cardiomyopathy 9 times out of 10. That's the most common cause of heart failure / cardiomyopathy in this country. So there's ischemic and there's everything else. I say this particularly because ruling out ischemia is one of the most important steps when we're dealing with systolic heart failure. We can often fix things. We can make the ischemia better and we might get their ejection fraction up. So that's why it's particularly important not to miss that diagnosis. So I wanted to show you some pictures, or an echo rather, just because the pictures are worth 1,000 words. So this is an echo of the heart. It's a girl. So this is the left ventricle, oops, where I've put my pointer there. So that's our main squeezing chamber of the heart. Next to it is the right ventricle over here, and then the atria are below us here. So this is a great way to look at this chamber. And I think you can agree when you look at it, that looks pretty good. Everything is squeezing, all the walls are moving towards the center, everything is getting thicker. So for us, this is a very healthy, normal looking ventricle. Okay, so now I'm going to show you a not healthy looking ventricle. So once again, we're going to put our pointer. Here is a dilated left ventricle. I see people frowning. Yes, it's very sad. This is a very sad looking heart. This is an end stage heart, in fact. So you can actually see over here, this person has a defibrillator in. That's a defibrillator wire going into the right ventricle. Everything is huge and dilated. And then if what you'll see in this person's poor ventricle, only one wall, this is the septum, but only one wall is moving. This wall is almost not moving at all. So this is a very sick, dilated, bad systolic failure heart. And if I'm a betting person, I'm going to say this is ischemic, particularly because one wall works better than another. That usually means there's an old scar from an old MI. So just to show you in pictures what we're talking about, this is the kind that I call you for with the urgent result, especially if this is unknown. This is a very sick, sad looking heart. So if we dive a bit more into systolic dysfunction, again, ischemic is going to be our most common. So I'm hammering that home because everybody with systolic dysfunction needs some kind of ischemic workup. My bias is a coronary catheterization, if that's a possibility, because we can fix something at the same time. A stress test is reasonable, but beware that when the walls don't work well, the stress test can sometimes also be uninterpretable. So for me, if possible, they go straight to the cath lab if we can. So then there's everything else. And there's a long list here, which we won't go into details of each, but just to put on your radar screen, other types of causes to be thinking about, because some will seem intuitive and others will not. Hypertension in and of itself over the course of time can lead to systolic dysfunction. Valvular disease is a very important cause of heart failure symptoms, but also systolic dysfunction. And I'll take a brief pause to kind of differentiate between those two. Remember that when you have, for example, aortic stenosis, we were talking to the residents about this yesterday. Aortic stenosis in and of itself, even with normal systolic function, will give you dyspnea on exertion. That's one of the symptoms of aortic stenosis. But over time, most of these severe valvular lesions can also lead to systolic dysfunction. And it can be tricky to figure out chicken or egg, but this is an important cause of heart failure syndrome, is valvular disease. There can just be a big ventricle for lots of different reasons. And again, we're not going to go through details on all of these, but just to remind us that there are other causes. And often my job as the cardiologist is to try and figure out which of these it is. it really only matters if you have a specific treatment. So for example, toxic alcohol or cocaine, we do have a treatment. It's called not using those substances anymore. But something like a vitamin deficiency, like thiamine, very rare in this country, but sometimes we see it, that can be treated with giving appropriate vitamin supplementation. And then another one I'll point out here, two more. Stress cardiomyopathy, you've probably heard of Takotsubo. That's the word that a lot of people use to describe this. I like stress cardiomyopathy better because it describes the pathophysiology. These are people who have an acute stressor. They get systolic dysfunction and then they get better. So I love this one in particular, and we can talk more about that in a later discussion. The other one I'll point out on this list is at the bottom, anthracycline. There's other chemotherapeutic agents which also lead to cardiotoxicity. This is a whole burgeoning field of cardio-oncology. But if you have a patient who's being treated with some of these cardiotoxic meds, then routine screening with echocardiograms and some biomarkers, BNP and troponin, is appropriate to try and see if they develop the cardiotoxicity. So just a list again of thinking about systolic, but the main point here is that it's ischemia and then it's everything else. So then we're going to move on to non-systolic heart failure. I'm specifically using that word, non-systolic, because this is more than just diastolic dysfunction. And here's where I think our terminology has gotten people a bit confused. This is any type of heart failure where it's not because the ventricle is failing. And I've listed what I consider to be kind of the four main causes, but mostly because I want to point out that just because it's non-systolic, that doesn't mean that it's what I call HFpEF. So HFpEF is really a diagnosis of exclusion. That stands for heart failure with preserved ejection fraction. Now, this is also not synonymous with diastolic dysfunction on an echo. And that's where this gets pretty tricky. So you can have diastolic dysfunction on an echo and have HFpEF, absolutely. But it turns out you can also have HFpEF with no diastolic dysfunction on the echo, which is so unfair, but that's how it goes. The reason for this is, again, what we said at the beginning. Heart failure is a clinical syndrome. And if you've gone through the wonderful workup that we all discussed earlier for causes of dyspnea, we're coming up empty-handed, but this person has true dyspnea on exertion, they have some edema, maybe some orthopnea. That person has the heart failure syndrome. And HFpEF is really then your diagnosis for that person. Echocardiography is good for looking at diastolic function, which just means the relaxation of the heart, but it's not perfect and it's evolving. So just because it says normal diastolic function on your echo or cannot assess diastolic function, don't let that dissuade you from this diagnosis if you've looked and ruled out everything else. That said, oftentimes I'll hear people say, well, this person has HFpEF, or this person has diastolic dysfunction. And actually, that's not what they have at all. We're going to go through some cases at the end to describe this, but I've had before where they have terrible right-sided heart failure, and they have a non-functional RV, and that's what their edema is coming from. That is not HFpEF, that's right-sided heart failure. Or I've had someone with severe aortic stenosis, and they were labeled HFpEF because they did have a preserved ejection fraction, but that is not the clinical entity of HFpEF. That's a different reason. So I think this is really important because right now, we don't have any specific pharmacologic treatments for HFpEF, but they are coming. They're going to happen soon, ongoing clinical trials. And so we want to get this diagnosis right so that we can be offering those treatments to our patients. So a couple other causes of non-systolic heart failure here, a hypertrophic cardiomyopathy. This is where we'll tell you the septum is huge and it's obstructing the outflow tract. This is a genetic specific entity with specific treatments. And then rarely, but we sometimes see infiltrative diseases. Hemochromatosis is one of the more common ones where we have that iron hemosiderin deposition in the heart, and they have restrictive physiology, which is different than just diastolic dysfunction. And then constrictive, very rare, but occasionally you have patients who've had radiation to the chest, for example, or recurrent pericarditis, and their heart is just constricted inside a very thick sac. So again, a different physiology than HFpEF. So I think it's good to keep these things in mind because unfortunately we put a lot of things into the HFpEF bag that probably don't belong there. And in fact, the one main trial to date of HFpEF therapy, the reason that we believe the trial was negative was because of this problem with diagnosis, in fact. And if you took 2 of the countries that shall remain nameless out of that trial, it's a very, very positive trial. That's for spironolactone. So I think that even in the world of research where we're very specific, we're still having troubles defining this entity. So let me pause there before I wanted to talk through some cases together and just try to categorize them based on what we've just learned. But any questions or comments on just how we can categorize these heart failure classes?
I have a question.
Sure.
When you're talking about the New York Heart Association class, do you think about that just based on your clinical history, or do you always want to see an echocardiogram to kind of make sure you use that appropriately?
Yeah, for me, New York Heart Association class is all about their symptoms. And so you can have a HFpEF and have a New York Heart Association class 3, so they have a normal EF and still be class 3 symptoms. But I just use that clinically. You might also hear about stages, stage A through D, if you've heard that at all. Stage A through D is more to do with what you're saying, the echo. So stage A is risk factors. Stage B is that you have a reduced ejection fraction or structural heart disease with no symptoms. Stage C is structural heart disease plus symptoms, and stage D is end stage. So sometimes I'll report both. Stage C, New York Heart Association class 2.
Thank you.
Thank you. Other questions or thoughts?
Dr. Bayan?
It appears that we were set up for being confused based upon the nomenclature that was set up. We were set up for this confusion.
Yes, I think that's absolutely right. And, this entity of HFpEF, that term wasn't even in widespread use during my training and fellowship, which wasn't that long ago. And so I think as this field and understanding evolves, you're exactly right. The terms have been used so interchangeably that we're having some confusion. So that's why this is a good conversation to have, so we can use them in the same way. The other thing I didn't mention is that you've probably heard this statistic. 50% of all heart failure is non-systolic, and people will use that interchangeably to say HFpEF, but we're really only scratching the surface so far. But I think you're right, we were set up for confusion. Have you all encountered this before where you've maybe seen a diagnosis and someone said HFpEF or diastolic dysfunction, but then as you dive in, you find some other cause of their dyspnea? Are you encountering patients like that? Or is diastolic dysfunction / HFpEF low on the agenda?
Dr. Van Gelder, could you unmute yourself, please?
Hi. So I think sometimes we get sidetracked with a lot of other issues in family medicine. So that's probably low on my general totem pole, unless I am trying to order like oxygen or some other type of home equipment for somebody with a diagnosis that's clarified as heart failure. That is an acceptable Medicare diagnosis. And I have found it very difficult to kind of figure out, one versus the other and find the right records that tell me which is which. So it's been challenging.
Yeah, and I think one of the reasons for that is we don't have any specific pharmacologic treatment for this disease yet. So when we do, I think it will become higher on our list to be looking for it. But even for me in my clinic, this is kind of maybe it's HFpEF, so let's diurese you and control your blood pressure and hope for the best. But I think over the next 10 years, we're going to see this paradigm shifting, and it will get a bit higher on our list. For me, the other challenge in being here in Nevada is sometimes I can't tell the difference between just elevation. People are moving here from California, and they're all short of breath. Every single one. I'm short of breath too. And so it's hard for me to figure out how long do I need to give them to acclimatize to this climate, or is it just that the elevation is unmasking this other problem that they have? In academic centers, there's more invasive ways to make this diagnosis, but I really don't move that direction unless I think, oh, this person maybe could be enrolled in a clinical trial. It's just not feasible or really worth it for them to kind of travel to a place where they could do an invasive right heart cath and make this diagnosis if all I'm going to say at the end of the day is diuresis.
Question here from Patty, is kidney dysfunction causative or just coincident?
Yeah, great question. And you're specifically talking about HFpEF, I presume, or heart failure in general?
Yeah, she's not.
Okay, HFpEF, yeah. So this is something, an area of active research that we're trying to understand. The phenotype of somebody with HFpEF certainly is someone with chronic kidney disease. So it seems to kind of track with this. What we don't yet understand is chicken and egg and which is causing the other. We certainly know about cardiorenal syndrome, where the volume overload of heart failure leads to kidney dysfunction because you have a decreased perfusion pressure across the kidney. They're like soggy sponges. HFpEF can certainly have that as well, but we're still understanding the kind of peripheral to central connections in HFpEF. So we don't really know yet, but they definitely track together. You're absolutely right there. Yeah, great questions. All right, and if there's nothing else, as I mentioned in our next month's talk is what the heck is HFpEF. So we're gonna dive a bit more into some details there and then talk a bit about some of the understandings of pathophysiology and some treatments coming down the pipeline. My best friend from training is like a world HFpEF expert. So we're gonna get it hot off the presses and all of the hottest information. But I thought it'd be helpful to go through some cases. These are, really pulled from my clinical experience of thinking about when we're approaching them, what type of heart failure would we think that they have? So for this first case, a 75-year-old man, history of coronary disease, multiple MIs in the past, previous tobacco use, quit last week, hypertension and diabetes, and then recently moved here to Reno from a lower elevation in California and just feels tired. But then the truth teller wife who accompanied him to clinic says that he is short of breath just walking down their long driveway to get the mail. And this is different and new than when they lived in California. No lower extremity edema, and he denies orthopnea or PND, but wife chimes in and says, yeah, but he's sleeping in a recliner. This is my favorite question to ask. How many pillows? No. Do you sleep in a recliner or in the bed? So if you had to guess for this man, just meeting him and hearing this history, assuming that his dyspnea is from heart failure, what type would you think he has?
California.
California heart failure. Yeah, from the cost of living. Yeah, so he probably would have a pretty common type, right? So this, to me, with his history of multiple MIs, screams that he's probably got ischemic cardiomyopathy with systolic dysfunction. Now, okay, for a further question, what New York Heart Association would you give this gentleman?
Dr. Van Gelder, could you unmute yourself? Oh,
got 4 options.
go ahead. What do you think, Dr. Van Gelder?
So he's not having shortness of breath at rest. So walking down the driveway, I'm thinking 2 or 3, but I would have to look at the chart.
Yeah, you know what? We often say 2 to 3. So that's exactly what I would say. We usually say 2 to 3 because those are the people who can still function in everyday life. By the time you get to really serious 3 to 4, they're usually needing to be hospitalized. So we hedge our bets sometimes and say 2 to 3. Okay, good. Yeah, so I think that he's kind of a good example of normal run-of-the-mill. When I get this echo, I'm fully expecting him to have systolic dysfunction. Okay, so now let's go to a different case. So this is a 55-year-old African-American woman, and she has had poorly controlled hypertension long-standing. Secondhand smoke exposure as a child, but no active tobacco abuse. And in my office, she's 155/89 with a heart rate of 95. And her main trouble is that when she's bringing laundry up from her basement, she has to pause twice on that staircase. And that's not normal for her. And then when I push a little harder, she says she's maybe gained 20 pounds over the last month. She also has lower extremity edema and 2-pillow orthopnea. So what would be your thoughts about this woman and possible causes of her dyspnea? And we're in heart failure clinic, so we'll just go ahead and say it's going to be a type of heart failure. And in her case, I think it's not as straightforward. There's a couple of different things that would be on my differential here. Any thoughts? We have a chat. Okay, hypertensive cardiomyopathy is a vote. That's absolutely on my list. So I would be interested in seeing, does she have thick walls on her ventricle, and does she have systolic dysfunction from hypertensive cardiomyopathy? At 55, that might be a little young because it usually takes decades, but if she had very badly controlled hypertension for a long while and we're only now starting to treat it, absolutely possible. So that's certainly one of the kind of 3 things on my differential. What other thoughts does anybody have here?
Hypertrophic cardiomyopathy underlying.
Yeah, so she is young and African American, so genetically she would have potentially a predisposition towards hypertrophic cardiomyopathy. Oftentimes those people have syncope as part of their presentation, so that would be something I would be asking her, is any syncope, and because they often don't get only heart failure as their only symptom, but certainly something on the echo that we're going to look for. Great. I have two other things.
I'll go.
Dr. Levi.
What about, again, just her demographics, being an African-American female, restrictive cardiomyopathy with sarcoidosis?
Great. So an infiltrative disease, yes. And if we got a family history of sarcoid, depending on where you practice, that can be very prevalent. Absolutely could be possible. It turns out pretty rare to develop heart failure from sarcoidosis, but I've certainly seen it. So yeah, that could definitely be on my list. I like those. Those are fun.
See that one for Dr. Lane.
Yeah, okay. So rule out coronary disease and new ischemic cardiomyopathy. Yeah, absolutely. If she has a depressed ejection fraction on the echo, she does have some risk factors, right? She has hypertension and secondhand smoke exposure. That's enough for me to say we need to rule out ischemic. Absolutely. So another thing I would put on this list, this is actually the demographic where I see HFpEF. A lot of times this sort of younger middle-aged, hypertensive African-American woman, that is a lot of the patients I've seen with HFpEF in my practice. Now, if you read the literature coming from Mayo Clinic, they only have elderly white people in Rochester, Minnesota. So they're going to tell you the demographic is a little old hypertensive lady. But when I practiced in Baltimore, I never saw that. I only saw African-American women with hypertension. So I think depending upon where you are in your demographic, it might differ. But I would definitely be suspicious and want to know if she, what her echo looks like and if she does have HFpEF for this woman. Good. And then I think those are probably the main things on my diagnosis. And again, you see that the echo gives us so much information, but I oftentimes, even before the echo, am thinking about what might this disease entity be. All right, great. Let's go on to our next case. So this is an 83-year-old veteran. So you know that means he's not going to complain about anything. He's just coming for routine follow-up, probably because someone made him. And the blood pressure is 144/110, which, usually at the VA, we're happy with that blood pressure, right? Pulse is 85, 92% on room air, so a little suspicious there. He has, when we examine him, as we always do, a very harsh 3 out of 6 crescendo, decrescendo systolic ejection murmur at the left upper sternal border, radiating to the carotids and an absent S2. And when I, start to push him to say, well, really tell me what's going on, he admits that he has slowed down and just takes his time walking or taking stairs. So he doesn't complain of dyspnea. He just says that he takes his time. But, you watch him walk into your clinic and it's a slow boat to China, right? So what are you thinking might be going on with this gentleman? All right, Dr. Bayun weighing in with aortic stenosis. Yeah, absolutely. This is a very classic presentation for aortic stenosis. It's the right age range. He's in his 80s. He's got a beautiful murmur. The most powerful thing for me in this is that absent S2. When you don't hear an S2, that's usually because if the valve doesn't open well, it doesn't close well. So you actually don't hear that. And that is a tip-off for me that this might be severe. And then classically, people don't do enough to give themselves dyspnea. They just slow themselves down because their body is telling them don't do a lot. So it can be very hard to pin down the symptoms from this, but you start to dive in and say, well, tell me about last summer. how far could you walk last summer, or could you, mow the grass or work in the yard? And then you compare that to now, and they've made a significant decline in their physical activity. So I put this guy in here to remind us that aortic stenosis can present with the symptoms of heart failure. But that, of course, is going to be a very different treatment regimen than run-of-the-mill systolic heart failure or even HFpEF. So this is a really good one to pick up on. And that may seem obvious, but I've had residents telling me the patient has HFpEF and when they have severe aortic stenosis. Those are very different, so good to remind ourselves. All right, and then I believe this is our last one. So this is a 32-year-old woman. She's seeing her OB, or her family practice, 1 month with a 1-month-old newborn. And she just says that she hasn't really gotten rid of some of this trace lower extremity edema that she had during pregnancy. And she started trying to exercise, but she is just very short of breath when walking on her treadmill, and says she hasn't shed any pounds, so she's very upset about that. There is this family history of, quote, heart failure in her mother and grandfather, but I don't know about when you hear these stories, but nobody ever knows details, like was it ischemic, or how young were they when they were diagnosed? Nobody ever knows, right? So there's this possible history of heart failure, but you don't really have any more details. And then on exam, she does have significant lower extremity edema, and her jugular venous pulsation is at the mid-neck when she's sitting at 45 degrees. So what might be on your differential for this woman? And please feel free to bring in non-heart failure things here, because I know your wheels are all spinning in family practice in particular here. Any thoughts with this woman? Or other information you want that I purposely left out from this discussion?
Just a second, Dr. Van Gelder. Go ahead.
Sorry. Sorry, I'm talking with my med student here too.
Good.
So is there maybe, postpartum thyroid abnormality, cardiomyopathy of some sort? I don't remember. There's something that I can't remember.
Yeah, absolutely.
Yeah,
I love that. Thyroid's a great one. And in fact, I hadn't even thought of that, but I love that. That's a great thing to think, because there's certainly big changes that happen there. And then, also several other people also mentioned thyroid. And then postpartum or peripartum cardiomyopathy, that is certainly on my list here. So this can happen during pregnancy, time of delivery, or up to 3 months after delivery, which sucks because it's called peripartum and you think they're through the woods, but they're not. We have no idea the pathophysiology, but these patients end up with systolic heart failure, all the symptoms thereof. About a third of them get better, a third of them get worse, and a third of them stay the same. And I think this is one of the big challenges, especially when you're seeing these patients in primary care or in family practice clinic. When do you get an echo? There's a lot of things that cause these symptoms in a postpartum woman. And so deciding when to pull the trigger and say, well, this degree of dyspnea or this degree of edema is out of proportion, I think that's a difficult question. It's easy for me because I have the echo by the time they come to me. It's harder for you to decide to get that echo. So that's certainly on the differential. And then Takotsubo or stress cardiomyopathy, that's also on the differential. Any stressor, physical, emotional, even good things. I've had surprise birthday parties that led to Takotsubo before. So just very powerful emotional experiences can do that. And in her case, let's say you got an echo and her EF is 30% with a global hypokinesis. I wouldn't know whether it's peripartum or whether it's stress cardiomyopathy. I would treat them both the same and I would see if it got better. And I still wouldn't know which of those it was. And then we'd have to counsel her about future pregnancies, and that would be a challenge. Okay, good. That's definitely on my differential. I got one more thing on mine. Actually, two more things that I would be thinking about. Any other data that you would want for this woman that you would order? What if I told you that she'd been really hypertensive during her pregnancy?
Yeah. I'd want an EKG and some labs.
Yeah, absolutely. So I think we'd have to think about, proteinuria, preeclampsia. Now I'm way outside my field of expertise here. But if she was hypertensive, we could still be seeing the residual effects of that. And the other thing that's going to be on my differential in my cardiology world is actually familial cardiomyopathy. So she has this mother and grandfather with heart failure. Now, who knows? Maybe they were both people who smoked and all that, but they could have a familial cardiomyopathy. When I get 2 first-degree relatives, I start to probe a little bit more, and pregnancy could certainly have brought that out for her. So that would be on my differential as well. Okay, good. Well, I think we're just about to time, and that's my last case. So thank you all for your participation. Just a reminder, your patients have heart failure, and a lot of them have non-systolic heart failure, and we're going to learn together about how to think more about that in coming sessions.